Welcome. My name is Peter Kelly, and today I'm here with Joseph Canchum from University of Alberta in Canada. And we're going to discuss Joseph's study, Circulating Interleukin-6 Predicts Carotid Plaque Severity, Vulnerability, and Progression in the Cardiovascular Health Study. So welcome, Joseph. This is a really good study. Could you tell us a little bit about the background and aims of your study, please?
Good morning. Thank you for having me. So in our study, we were really interested in finding out if we can improve the prevention of stroke due to carotid atherosclerosis. So when looking at previous studies or trials of anti-inflammatory drugs for cardiovascular prevention, notably the CANTOS trial, the COLCOT or the CERT trials that trialed various anti-inflammatory drugs, what we noticed is that when they considered all the cardiovascular endpoints altogether, like with a composite endpoint, they found a benefit of anti-inflammatory therapy. But when they considered stroke specifically, there was no benefit. So the trial were neutral for that specific endpoint. And we thought that this could be explained by the fact that not all the strokes or the stroke events recorded in those trials were attributable to carotid atherosclerosis or attributable to large vessel atherosclerosis in general, that there might have been some cardioembolic strokes or lacunar strokes that could not be prevented by anti-inflammatory therapy. So the hypothesis behind the study was that if our interpretation of the data is true, then we should be able to find a relationship between markers of inflammation, notably interleukin-6 in this study, and features of high-risk carotid plaques, notably the severity, the vulnerability, and the progression. So that was the rationale for undertaking the analysis that we present in the paper.
So how did you go about then addressing your hypothesis?
Yeah, so we identified one database that contained information on plasma or circulating interleukin-6 and information about carotid plaque features, severity, vulnerability, and progression. And that was the publicly available database of the Cardiovascular Health Study, which was a prospective population-based cohort study in the US, enrolling patients aged 65 and above that were community dwelling adults, and recording information on the carotid atherosclerosis using ultrasound and at baseline, and then following them up over almost a decade and recording the same information on carotid plaque features at 5 years, at 7 years, and thereafter, to identify if there's any change in the severity of the narrowing of the carotid atherosclerosis. And they also measured these levels of interleukin-6 at baseline, plus all the other classical cardiovascular risk factors that we usually take care of or consider when we do these kind of studies, like hypertension, diabetes, smoking, dyslipidemia, and other ongoing treatments.
Excellent. So you identified a really rich database in which to analyze and test your hypothesis. So how did you identify the various metrics of carotid atherosclerosis that you studied? How did you define severity, vulnerability, progression, etc.?
Yeah, thank you. So the severity was mainly based on the NASET grade of stenosis that we use commonly in clinical practice. But in that study, it was called 0 to 5. That means 0 for a normal carotid artery without any plaque, and 5 for carotid occlusion. And in between, they had 25% increments or categories, like from 1 to 24%, it was called 1, while something like 75 to 99% was called 4, sorry, because 5 was occlusion. And plaque vulnerability was defined as echolucent plaque or markedly irregular plaque. That means the the irregularity was between 0.4 to 2 millimeters in terms of depression, and all ulcerated plaque if they had the depression greater than 2 millimeters. So ulceration, marked irregularity, or echolucency were the three parameters to define vulnerability. And then the progression was an increment of at least 1 point on the carotid or plaque severity score between baseline and the 5-year follow-up ultrasound examination. And all of these were considered for both carotid arteries. That means if you had these features of vulnerability on one side, or on both sides, you were considered as having plaque vulnerability, and progression what could be on one side or on both sides also. And for
can
the
you tell
severity,
us, please go
sorry,
ahead.
for the severity, we considered the maximum severity at baseline. That means it could be plaque on both sides, but we considered the maximum.
And can you tell us how many patients in your cohort had a history of stroke or TIA?
So stroke or TIA you mean in the history of, or
Yes.
during follow-up? Also in the history, can't remember exactly the number, but I think it was probably less than 20%. I think I would need to check back on that number.
Okay, so it was a largely primary prevention or asymptomatic cohort from the perspective of cerebrovascular disease.
Yes, exactly. So in total, I think patients who had either stroke or TIA or myocardial infarction or peripheral artery or symptomatic peripheral artery disease before enrollment, there were a bit more than 900 of them. So I could say 1/5 of the entire cohort before excluding those that didn't have complete data.
So what were your main findings?
So we found that circulating levels of interleukin-6 are independently associated with carotid plaque severity, with carotid plaque vulnerability, and with carotid plaque progression. So for carotid plaque severity, or the relationship with carotid plaque severity, we did use a linear regression to study the association. And we found that, for example, for one standard deviation increase in the levels of log interleukin-6, we had a 0.08 increase in the carotid plaque severity score, which goes from 0 to 5, as discussed earlier. For carotid plaque vulnerability, we found that there is a 12% increase in the probability of having those features of vulnerability on carotid ultrasound per one standard deviation increase in log IL-6 on the in the logistic regression. And for plaque progression, we found that there was a 24% increase in the probability of having progression at 5 years per one standard deviation increase in the levels of log IL-6 at baseline.
So what are the implications of your findings for either current practice or future practice?
So I think one of the major conclusions that we could draw from this is that the contribution or that inflammation has a contribution to vulnerability or destabilization of carotid plaques and progression of carotid plaques that is independent of that of dyslipidemia, which means that we could, adding an anti-inflammatory treatment to the current best medical therapy, including antiplatelet drugs and lipid-lowering drugs, could improve the prevention of stroke or carotid plaque progression in patients. So we certainly need to test this hypothesis in trials of anti-IL-6 drugs, targeting specifically those patients who have a carotid plaque and finding out if it helps to decrease the incidence of ischemic strokes due to that carotid plaque during follow-up. And another thing that we identified, which I didn't mention earlier, is that also hyperuricemia was independently associated with plaque vulnerability, for example. And there are already drugs that are prescribed to decrease the blood levels of uric acid. And that could also be another intervention to decrease the risk of stroke due to carotid atherosclerosis. Of course, we also need a trial for that, but it would be a readily available intervention beyond the control of cardiovascular risk factors and lifestyle modifications.
Fascinating data, Joseph. Thank you so much for joining us today and sharing it with us.
Thank you. Thank you for having me.